Thank you, Dr. Goldberg. We good? And thank you all for sticking it out and staying here this afternoon. I see some fellow Wisconsinites in the group. Did I say that Wisconsin well enough? Okay, there we go. So today, my goal is really to kind of give you an introduction to what advocacy is, why it's important, and some structure around it. And then our follow-up speakers will go more into detail with that. I have no financial disclosures, as Ross said. I do hold a number of positions with the college, which is where a lot of my experience with advocacy has come from, and then also some statewide work as well. So we're going to talk about what exactly surgical health policy advocacy is. We'll review the spectrum of advocacy engagement and all the different levels that you can be involved, and the importance of engaging in this as a surgeon. So what is advocacy? The textbook definition, if you will, is simply an act or process of supporting a cause or proposal. Common examples that we're used to seeing are the AMA, the NRA, of course, and the media the last number of years. School associations, realtors, and lawyers are known for having very strong advocacy groups and political action committees. So oftentimes we think about big money being required to be involved in advocacy, but that's absolutely not the case. Grassroots advocacy is incredibly important, and for the most part that doesn't cost any money. It just takes time and your involvement. It's also important to know what advocacy is not. It's not dirty, it's not wrong, it's not corrupt, and it's not for other people to do. And I think this is slowly going away as we're all sort of seeing the importance of being involved in all sorts of political landscapes and joining the discussion. But unfortunately, this does still exist out there, that people think that this is not something that you should be involved in your professionalism. So then what is surgical health policy advocacy specifically? So it's the addition of act or process of supporting cause or proposal, but specifically geared towards the surgical patient population, the surgical profession, and improving surgical care delivery. Really, it's important to keep the surgical patient and surgical profession as the cornerstone of the purpose of the advocacy work that you do. So why is advocacy such a challenge? A lot of it lies in the definition. At least in academia and most parts of medicine, classic science is laid out as having a well-defined methodology. People know what it means. It has notions of reality that are felt to be grounded. It's precise in its agent, its host, and its environmental factors. Basically, we know what classic science is. Advocacy doesn't have those characteristics for the most part. A lot of people don't really know what it means. It involves a dynamic interplay of factors and influences that are often beyond those who evaluate what it is, their control. And as surgeons, we all know how much we like control. This does not fit well with that. It often also seeks to change upstream factors, something that also as surgeons we're not very used to. The problem has already presented itself to us and we're now fixing it. Advocacy looks to fix laws, regulations, policies, and institutional practices. None of these things are easy to change. It also looks to address prices and standards and influence personal health choices. Again, oftentimes we're much further downstream than this in our clinical practices. Chapman described this quite nicely, that advocacy is not for the faint-hearted, that it can take on the specter of fraught, politicalized activity, and even threatens to make enemies, particularly of retributive government figures and litigious industries. Doesn't that make you want to get involved? What are some other advocacy challenges? Really, it's similar to public relations. It's putting our face out in front of other groups, populations, and we're oftentimes faced with contested definitions of what is at issue. We have different opinions on it. We can bend the facts to look different ways. And oftentimes it's mixed in with public conflict. There's powerful interest groups or governments that are determined to resist change. We see this every day on our nightly news with discussions of fake news and real news. What do we actually believe? It also involves contested values. There's perceived injustices. Oftentimes there's disempowered communities and people who don't have as much resources. And there's mistrust of science and authority. We also see that daily in our news watching. And this is a contested thought. Data can't always solve the problem. We need data, but data is interpretable, and we need to be able to interpret that data for people, or people will interpret it how they want to. Beliefs, values, and opinions are supported or disputed by data must be engaged for the process to move forward. We must stay engaged with our data in order to help people understand what it means. Ernest looked at this in 2010 and defined some barriers to physician engagement in general to advocacy. And he really defined as well that academic success, in the past has required hard science, at least social sciences and population health, but the activity of going out and engaging others and to share opinions is not something that has been recognized well in academia to this point. It's ambiguous and uncertain. Again, we're used to complex processes, but we want to have certainty and data behind it. There's a lack of immediate gratification that particularly as surgeons we're very used to, and it requires relationship building, and that takes time. Who has time? Not surgeons, right? Also, the government is complicated. It's been a long time since any of us have taken civics courses, and to understand all the complex interactions is difficult. Clinically, we're simply too busy as doctors. There's lots of EHR things to fill out, patients to see, always something more to be done. And we've been trained in our residency programs and even medical school to keep our personal and political opinions to ourselves. Again, I think this is slowly changing. Schools of public health and medicine are engaging students to be more thoughtful and to share opinions and to interpret data. However, that has not historically been true. It may also put the practicing surgeon at conflict with their personal agenda. So what we do with our professional thought may not be what we do in our personal lives, and it may put us at odds with our hospital or organization for which we work with. And this is a very sticky place to be. And so defining who you're speaking on behalf of at what time becomes very important. And then, of course, partisanship also complicates the problem. So why the heck should we start something new? Why should we engage in advocacy? Well, I argue that there's nothing new about it. Even Hippocrates, which we all spoke the code of, that I, the physician, will be an advocate for the patients in need and strive for justice in the care of the sick. This implies the population of patients. Dr. Rudolf Virchow, politics is nothing but medicine on a larger scale in the early 1800s. And the AMA weighed in as early as 1847, encouraging physicians to advocate publicly. So surgical health policy advocacy engagement, how can we as surgeons actively engage in changing the face of healthcare? More importantly, I ask, why should we? Patients, I think, are the #1 most important goal. This is what we did all of the work for, did all of our training for, and we need to keep this at the cornerstone of making sure that we provide all of the care and regulations for them to receive care. The importance of patient-centeredness we all experience in our daily practices. Changing reimbursement is a constant threat. Team-based care becomes more and more important. All of medicine and surgery is a team-based sport, and we must be at the table so that we don't lose our important role. And quality and satisfaction reporting. This all seems like a good idea, but interrupting our busy clinical practices can be a real challenge, and so we must make sure that as we're trying to improve quality, we're not impacting the care and the time we have to spend with our patients. So the definition of a doctor and surgeon is simply a teacher of medicine, and all of us as surgeons actually mean that we use our hands to work. So we are simply teachers who do stuff. We do this every day in clinic, we do this every day in the operating room, explaining why a patient needs a procedure, what the complications are, what the risks are. So how does the activities of what we're doing with our patients relate to what's happening in DC, in conference rooms, and in our state capitals? There's a lot of similarities, actually, because there is a problem that we're all trying to solve. In medicine and surgery, it's a disease. We as physicians and surgeons, we heal and repair people, and we ameliorate pain. As patients, patients are torn between the care that they have, the sacrifice it may mean to their family, the cost to themselves, and the cost to their family. Really, this is no different than advocacy, especially when most of this deals with costs, laws, regulations, or lack thereof. Dealing with budgets, advisory regulations, reimbursements, patient coverage, and insurance. These are all very well related, just different from the individual level to a population level. So does this make us all just a bunch of fish out of water? If surgeons don't pay attention to federal and state policy and participate in it, the patients are going to suffer. The access to care that they get and the cost of that care will be in trouble. More trouble than it is in currently. There's competing efforts by other specialty groups, and instead of competing with them, are there opportunities for us to collaborate or compromise, again, for the benefit of our patients? Remember, if you're not at the table helping make these decisions and influence policy, you're most likely on the menu. Advocacy is a spectrum. We all engage in patient advocacy every single day. Do they get the chemotherapy? Do they get insurance coverage? What can we do to get the care that they need? But how do we broaden that out to local advocacy, addressing your hospital system or the community issue? What fall prevention programs do you have for the elderly or child safety systems of what you can provide? And then broader at your state level. Does your state have laws regarding helmets? What are the budgets? How does injury prevention provided? Scope of practice, et cetera. And then at federal level, this really gets into budgeting, particularly resource allocation, injury prevention. These are complex issues with lots of charged partisanship behind them. This is another way of outlining the spectrum. So state and federal, obviously there's going to be issues that overlap. But what about the legislators? Do they really want you traipsing into their office and talking to them? Wouldn't they rather just come see you when they have a cough, a cold, or appendicitis? This paper actually looked into reviewing that, and they actually do want to hear from you as a physician. They respect your opinion. They know you are a leader within the community. Remember, your patients are their constituents, and you are their constituent as well. What they want to know from you are stats and population level data, and they want to know your patients' stories. How do these things affect them? Remember, they're living in a microcosm within their offices and boardrooms, so they don't get in to see what it's like to be a patient unless they've been a patient themselves. It's also a great opportunity for you to bring them to your hospital to see what they do, so that they can see what you do. Advocacy is also a dissemination of research, and I think Dr. Dimmick will get into this more. But remember, research depends upon impact factors, national meetings. This is slow distribution within the medical community itself. There's a role for appropriate vetting and academic method. Surgical health policy advocacy is more about communicating. How do we take the current research that we have and put it into current policy and informing policy formation? Communication of expert and clinical experience to really share with the legislators what it means to take care of patients on a day-to-day basis, and then distributing information to a population level. Wanted to quickly run through how complex Congress is in a very simplified manner. The House is 435 seats, the Senate 100. Bills are introduced, they go to committee, hearings are held, and revisions are made, markup. These are all the really boring parts that we don't really get to see on the nightly news. At this point, it may then advance to the House or the Senate, and whichever chamber it goes to, it then has to go back to the other chamber, and the process is repeated. Once this goes around and lots of time has passed and everyone's had a chance to impact it, it goes to a conference committee so that the language can get put together, and then if it gets repassed by both chambers, then it can go to the president for signature. No wonder as surgeons, as physicians, we don't have time for this. It's tedious, it's long, it's all process-oriented. This is not surgery. However, there are similarities to the complexity of medicine, the long process. If you think about a patient diagnosed with cancer, all that they need to go through before they actually get to their resection and further out, there's many chances for disruption, et cetera. Legislation versus regulation. Legislation is what we all often think about. These are national and state debates. They're emotionally charged oftentimes. The media is over them. We have legislative days to talk and argue about what the positions should be. It's political. In many ways, this is very sexy, right? It gets the headlines. People get broadcast about what it is they're talking about. However, this is a small part of government, and where a lot of the work, probably the majority of work happens, is through regulation. This is much more mundane. It's muted, but the effects of what happens in regulation are far-reaching and impactful. It can be very surprising. So a law gets passed, and what the regulatory implications of that is what affects our daily lives and is very potential to cause pain, quite frankly. And a lot of this also has to do with funding issues. Government regulations, things like the ACA and how that actually happens. This is what affects the makeup of your career. Number of resident training slots, reimbursement, how you get paid, prescribing practices, medications that you have available to treat your patients, IV fluid shortages, drug shortages, et cetera. So why get involved? I argue it's your professional obligation. You are a constituent to your elected officials. You hold a respected position in your committee, and your patients are constituents. You have a growing influence within government, and you have a broader difference for your patients that you can make. And it also makes you a more well-rounded person to understand all sides of the issue and to be able to speak to them, to the elected officials. So how can you get involved? Pay attention to the opportunities around you. Coming to meetings like this is a great step. There was a great workshop here at SAGES on Wednesday. I'd encourage you to participate in more of those activities. There's specialty society legislative days in DC and at your state capitals, conference calls, et cetera. Pay attention, watch the news, even Facebook and Twitter. There's feeds that get put out, even just in announcing this session. Join an organization. There's newsletter summaries, so you don't have to work very hard to find this information. It's summated for you. Meet with your congressional members and simply vote. Write letters to your congresspeople, make phone calls. So does any of this matter? Yes, it takes very little actually to make an impact. Most people don't vote. Most people don't register. I guess it's up here. Of those that register, it's only about 60%, and only about 50% of people actually vote. Even fewer people donate money. So if you write a check to a legislator, guess what? They're going to pay attention to what you have to say. That's the connection people don't want to admit to, but it's just how the world works. The good news is it doesn't have to be very much money to make a notification. Also, if you're donate to a PAC or an organization, you can give money on behalf of that organization. So you get the credit for it, share your opinion, but you're not putting all of your money into it. And look, very few people volunteer. So if you show up to help with a campaign or show up for a panel, that is making you stick out. And then as an important member of your community, as a surgeon, your opinion is heard even more. I'm going to go through this. So again, contact your representative. It's simple to reach out. Send an email, letter, a phone call. Stop at their office when they're in your district. Take a photo. Put it on Twitter. These are the things that get noticed. Write a letter to the editor in your state paper, your local paper, or online. Attend meetings, build relationships. That's what so much of this is about. Schedule a tour. Bring them to your hospital. I love taking our elected officials through our trauma center. Our lieutenant governor had a stage 3 colon cancer during her election in her mid-30s. This is very public knowledge, and she's given me permission to tell this story. I brought her in to tour our level 1 trauma center. She had no idea, even though she was a very high user of cancer care, what trauma included. So that was a great experience. And so they love coming out and taking a field trip, so to speak. Do it yourself or support a PAC. It doesn't have to be much money. Engage your colleague, involve your students, talk to them, let them know the frustrations you're having with medical care. It's going to be at their doorstep soon, and involve your patients. I do this more and more every day, and my students are shocked when I talk to them, but patients actually really like it. They want to know that you're engaged in their care, not only in doing their surgery, but in making sure that the care that you provide continues to be provided for them.